the pandemic, and it will be, well, we can't ignore it because it's the biggest health issue over the several decades, and will be a bit of a recurring theme throughout the year because of its historical significance. I'd also like to thank Gamze, who's on the call, who's our HIMSS rep on council, because she's been instrumental in organising this, and I just wanted to put our thanks on record for that. So as we get into the meeting, I think the previous slide talked a little bit about, we will, obviously, if you've got questions, pop them in the chat box. We can also take some at the end if we've obviously got time. People want to spend a bit of time afterwards asking specific things, but I'll take them after Farah's talk as we go through in the box. So I think without further ado, welcome. Thank you for joining us. I hope we have an interesting, informative and educational evening. I'm sure we will, from the comfort of our own homes. So I think the screen is yours, as we like to say. Good evening.
Let's go. Everyone see that okay? Great. So hi, everybody. Thank you very much for having me. My name's Farah Shahi. I'm an infectious diseases and microbiology registrar. My clinical base was actually Hull, and then I moved down to Sheffield just before the pandemic in August 2019 to try and do a PhD. As has been alluded to, Gamze contacted me via my Instagram account, and so in true influencer style, I'm going to be talking about the pandemic from my point of view and using what I've put on Instagram as a sort of time point as to how we got where we've got, really. So going back to the very beginning, on the 31st of December 2019, after what seems like a very long ago and quite lovely Christmas, the WHO announced this novel coronavirus from China. And PHE testing guidelines in the UK were initially very restricted to Wuhan and then Hubei province, and then eventually to China. It's very difficult to actually find these guidelines now because they were so rapidly updated right at the beginning, and everything else was then withdrawn. But these two papers in particular still give me goosebumps. The first paper on the 24th of January is about a family cluster of this novel coronavirus pneumonia. And they basically managed to CT scan pretty much everybody in the family, including children. And I remember at the time, we were still worried that there was a potentially 10% mortality associated with this virus. Bear in mind that SARS-CoV-1 has about a 10% mortality, and we know that MERS has a 30% mortality. But what we did know was that this was quite transmissible, even from the get-go. And so we were kind of hopeful, and this doesn't translate to actuality, but sometimes when things are less transmissible, they can potentially be less deadly. Obviously, Delta is a good example of how that's not always the case. But this second paper on the 30th of January was about the genomic characterization. And if you want to read some absolutely beautiful science, I highly recommend this paper. It will forever be one of my favorites, talking about how they isolated the virus, how they worked out the sequencing for it, and how they provided us with the PCR testing so that everybody was able to test. And to be honest, they managed to do that by about the 12th of January. And actually by the 27th of January, the first two cases were diagnosed within the UK, and they were actually diagnosed and managed by my colleagues in Hull. So very early on, it already felt like this was touching friends and loved ones very quickly in a way that SARS-CoV-1 didn't have the same impact. Now, the HCID network was set up during the Ebola crisis, so that we can manage and contain any potentially infectious diseases that come into the UK. And so ID very early on took control of this, and I'll come on to why that might not have been great overall in retrospect, but it's difficult. This was actually also the first probable person-to-person transmission to occur within the UK, because one patient gave it to the other within a UK setting. And by the 8th of February, we had this poor chap called the Brighton super spreader, who I don't know if you remember, but he was a chap who'd been to a business meeting, I think, in Singapore. Singapore's track and trace system is exemplary. And they contacted him and let him know that he'd had a positive contact. And on his way home, he'd stopped via a ski resort. Ski resorts were particularly dangerous at the beginning of the pandemic, and infected a lot of other people. And it turns out that he was completely asymptomatic. And from an ID point of view, this kind of changed the game, because we now knew that you could have true asymptomatic spread of this infection. And then it was about, how good or bad is that in the context of whatever mortality we're going to actually find that this has. PHE testing guidelines expanded at that point to cover far more of Far East Asia, from memory again. And by the 29th of February, we had our first confirmed UK transmission of a chap in Surrey who had no travel history and no contact with anybody who'd been traveling that he was aware of. So it was our first clear UK case, and was significant in the sense that it meant that we had community transmission. But by early March, I feel, I don't mean any criticism to PHE, they've been working incredibly hard. But by early March, we were still doing things like closing off to our lesser allies in the world, if you like, and then politically prioritizing our own actual allies. For example, we shut off to northern Italy, and I'm sure that was a partly governmental decision rather than the entirety of Italy. But we're still very much focusing on the Far East as where we should be testing people from. But by the 23rd of March, it was very apparent that we needed to go into lockdown. So at the beginning, my Instagram account was mostly to just communicate the things that I loved about doing ID and micro, and help me, learn by teaching. And in the top left is a picture from Nepal, and in the bottom right is a picture from India. And it was just at the beginning that I'd started to do my global health PhD project, and I was really excited to be able to share that. And then things kind of changed. So by the 23rd of March, it hit everybody and we went into lockdown. And this is the bit that I mean in terms of how the HCID network was almost overprotective, I think, because this seemed to be a massive shock for the general public. Now, I said goodbye to my uncle, bless him, who passed away, and also my parents on Valentine's weekend of 2020, because even though I knew I wasn't working clinically, I just knew that there was a high chance that actually I was going to have to. But for everybody else, it was a shock. And that included quite a lot of the NHS who'd been protected by this amazing network, which is a great network, and by other ID units throughout the country who'd been taking the brunt of all the testing and the tracing. And actually, in retrospect, I think we probably should have been better at preparing the entire NHS workforce that this was a significant possibility. So yeah, we got to wave one. And in wave one, there was an awful lot of panic buying. As I said, it came as quite a shock, I think, to the general public that this was something that was touching on their doorstep. And everybody kind of acted like it was a bit of an apocalypse. And that's where the sort of masking idea sort of came in, because we had a lot of people trying to panic buy masks. I had a lot of questions on Instagram about, should I be going out and getting a mask? And the advice at the time was don't. And the reason for that was partly because PPE was precious, and as I'm sure you'll all remember, was quite scarce at the beginning of the pandemic, Italy and China being our biggest providers of PPE, and they were kind of busy. But also our prior experience of using masks in terms of infections really came from TB. So TB is droplet spread. If most of the time we will go in to protect ourselves, we will wear that PPE. And the only time we really use it to stop the patient from spreading is, say, we take them to X-ray and we'll ask them to wear a mask in order to get to X-ray to reduce their chances of passing it on to somebody else. So the idea of rolling this out to the general population, we didn't really have the data to back that idea up. And actually what soon came about, as again you all know, was the fact that we decided that actually there is now evidence increasingly that the wearer who's infected can protect others by wearing their mask. And again, this is actually I'll come back to that, but this is an image from a fantastic little paper where they found a low cost way of measuring mask efficacy. So they basically set up a mobile phone camera in a box pretty much, and they got a chap to wear a mask and then talk and shout and sing, and they measured the droplet spread or the aerosol spread that occurred from that. And the mask, the graph, looks slightly scary in the fact that if you look at the net gaiter on the far right of that first graph, you can see that the net gaiter, which is like a buff if you use those, was worse than not having a mask at all. But the confidence intervals on that were hugely wide because I think they only had one case of it. So actually, this is where I start to talk about messaging, because that became a huge thing within, in particular, the US media, that net gaiters were worse than anything else in terms of spreading COVID. But the whole aerosol versus droplet spread is fascinating. And if you get the chance, I'd recommend there are loads of different pop science articles now written about this. From a medical point of view, if something is aerosolized, that has implications for what sort of PPE that we use. Whereas if something is droplet spread, we use different PPE. From a scientific point of view, the size of an aerosol particle is what determines whether it's an aerosol or a droplet. And so technically, there was evidence that it was aerosolized, COVID, the virus, and scientists, I think, were getting so frustrated because members of the WHO were unwilling to say it. And maybe what they don't fully appreciate, I think, is the level of fear that there was amongst healthcare professionals at the very beginning. So in Hull, we had 12, we've got 12, it's a 12-bedded ward, and we've got specialist setups for certain rooms so that we could have people who are having aerosol generating procedures, for example, high flow oxygen, and we could then wear this PPE in order to go in, the sort of spacesuit type, Ebola type PPE. And at the time when I came back, they just downgraded the PPE to be a surgical mask, gloves and a gown. And that was hard for ID physicians and nursing staff to get their head around. It makes you feel a little bit more vulnerable when you've spent the last 3 months wearing this instead. But it was also really hard for those who were having to step up, who weren't part of ID, who were really fearful about the fact that they couldn't wear a spacesuit, even though they didn't necessarily know how to use it properly in a way that was protective for them. But it is a fantastic debate. And thankfully now, the WHO has finally said, yes, there is aerosolization, in a wording that I think is important from the scientist's point of view, in terms of ventilation being important in reducing spread. Now, the NHS is incredibly important, well, generally, but also for the fact that in terms of our research output, that genomic sequencing, those have been our best things out of the UK. And part of it is because the NHS is set up as this single organism, if you like. Compare that with other parts or other countries, and you'll find that, unfortunately, with different fragmented types of healthcare system, it's a lot harder to run the sort of trials that we've managed to put out. So particular fantastic trials that we've had, obviously there's the Oxford vaccine trial, which I'll come on to, Recovery, which looks at repurposing drugs, ISARIC, which is actually originally a UK tool adopted by the WHO for epidemic and pandemic situations in terms of observational monitoring, and the SIREN study, which basically looks at the immune system of healthcare workers over time, including pre and post vaccination. And I have to say, the research output that we've had from the UK has been absolutely fantastic. So coming on to the Oxford vaccine trial, by the time we started to set that up, it was around, I think, May, June time. And at this point, things had started to improve in terms of hospital admissions, and it was a fantastic thing to be part of. And I have to say a huge thank you to all of the volunteers who took part, because looking back, it was a scary thing for a lot of people to do. But I thoroughly enjoyed my time working on the Oxford vaccine trial here in Hull, and I've worked on spin-offs of the Oxford vaccine trial here in Sheffield as well. I think it's just one of those incredibly significant things to have been part of. But my love for it isn't really just because I've been part of it, but I'll come to that at the end. So, as I've alluded to, Recovery is a fantastic trial. And by the 16th of June, they announced that, much to, I think, every ID physician in the country's surprise, that steroids were actually fantastic at reducing death rates in people with COVID. And it's really our first treatment. So I don't think I've got a pointer, have I? Does that work as a pointer? Bear with me. Mm. There you are. So can you see that okay? So essentially, if you look at this first graph, the Kaplan-Meier graphs of survival rates, basically, you can see that dexamethasone is better than usual care. You can see that with invasive mechanical ventilation, that difference between dexamethasone and usual care, which at that point consisted largely of oxygenation in various forms, dexamethasone was significantly better. You can see again the same thing with oxygen only, but you can also see that if you give dexamethasone to somebody who's not receiving oxygen, which suggests that point in COVID where you get a hyperinflammatory response that kicks in, then actually there's a potential harm with dexamethasone versus usual care. And again, this pretty much says that the confidence intervals around invasive mechanical ventilation are obviously slightly wider owing to the smaller number of participants involved. But with the oxygen only, there's a clear benefit of dexamethasone. And the really important bit about that is that actually it's something that is generic, it is easily available all around the world, and it's something that can be easily given at a point in time where you know that somebody would need oxygen. So by the 23rd of June, we were thankfully coming out of lockdown, and at this point we had 888 cases. Now, one of the issues at the very beginning of the pandemic was that we didn't have enough community testing. And in retrospect, unfortunately, the responsibility and control over testing wasn't relinquished, I think, soon enough to general hospitals and then out into the community as well. And I think it's something that we need to reflect on, because actually we need to take a bottom-up approach with things like this, if heaven forbid it happens again anytime soon. So as a result of this, you get this plateau effect in that first wave, and that's simply because the number of people who were tested were far lower than the number of people who actually had the infection out in the community. This is really just hospitalized patients. This is what you expect to see in a proper pandemic curve. You see this incredible uplift and then a peak, at which point everything starts to come down. So by the 23rd of June, we had 888 cases. And I think most healthcare workers who've been working every day didn't fully appreciate how horrible lockdown can be for the general population. But then the government decided to add this frankly ridiculous idea of an Eat Out to Help Out scheme, which is probably one of the worst ideas during a pandemic that I've ever heard. And there's actually been data subsequent to this which proves that this had an impact on our COVID rates once it happened. But the effect of travel is actually really interesting. So this is a paper looking at the genomic sequencing of various samples early on in wave 1. So it's not matched for where a person comes from. The sequencing data is what tells you which country the virus probably originated in. And even though at the time we were shutting off to Italy, actually the majority of our imported cases came from Spain and then France and then a mix of everywhere else. But note that pretty much all of them are European countries. And then you've got here China, a really small number, and the same for the US as well. And in the post-match analysis, the Home Affairs Committee stated that actually, you know, it wasn't just the UK who made this error. Obviously, a lot of other countries did that as well. We know that fantastically, there was absolutely no border control between I think it was about the 13th of March and the 8th of June. And actually the messaging around travel and what the risk was needed to be better communicated with the public from here on in. On top of that, we needed to think about border testing. And I think it still took a while after June for that to really come in. But even so, when you look at the mathematical modelling around this data in terms of imported cases and how much it impacts. So if you remember early on with the WHO, they were not keen for people to close their borders. And that's partly because it's an international, it's a human health right, basically, or a human right to be able to travel back to your home country and travel to another one, essentially. But when they looked at the data for it, less than 10% of the total incidence in 103 countries actually was due to imported cases. And I think the key thing here is that even though that probably is the case, I think border control is probably going to be more important now moving forwards in terms of new variants potentially coming in from a largely unvaccinated rest of the world. But also, if you look at New Zealand, for example, they managed to shut down quite early and protect their community quite well. So actually, I think it's more a case of once it's in, it's in. And unfortunately, it was in for us far before I think we really detected it. So come August 2020, I went back to Sheffield to try and do my PhD, and I had to settle into a new normal, which wasn't actually this. This is fairly recent. I managed to get into the lab most of between August and about June time, apart from helping with vaccine trials. I experienced this feeling of lockdown that other people had had before. And having done both sides, I have to say it's a very isolating experience being in lockdown on your own. But by Christmas, we had a lot more hope. There was a real potential of having a COVID vaccine, but there were also shed loads of rumours going around about what these vaccines could or couldn't do. And it became really obvious that actually most people had fairly similar questions. So I contacted other psychommers on Instagram, and we created this 8 frequently asked questions about vaccines in order to basically try and help prepare the general public as much as we could from our own small platforms. But then by November, we had the Pfizer vaccine, and this is extraordinary. I mean, you can see that on their graph here, that if you look by about day 10, you get this complete split where those who received the saline placebo had virtually, no well, they didn't have protection, whereas you can see this fantastic protection coming in from the vaccine itself. And the amazing thing about this, as you all know, is that it's a new type of platform for making vaccines, which has huge implications potentially for other infectious diseases in the future. The thing to get round, though, is this whole -80 freezer issue. Moderna tried to do that by switching out some of the bases and trying to keep it at -20 instead. But really, it was fairly obvious that this was a vaccine predominantly for certain parts or certain areas of the world. Now, in the meantime, we were still trying to cope with our own community spread within the UK, and lateral flows have to be one of my favourite things. So my PhD is actually in diagnostics, and I really love the lateral flow tests. I think they're fantastic. We had a meeting that Susan Hopkins kindly organised to let ID physicians know about the lateral flow test, because essentially there was a lot of confusion, I think, in the newspapers about what they were and what was going on. And this is one of the graphs from it, and it's actually in the report that I highlight in the next slide. But essentially, having a high viral load meant that you would pick this up. But at lower viral loads, so when the CT value was high on a PCR test, actually it wasn't so good at picking that up. But the people that you want to catch are the people with the highest viral loads, whether they're symptomatic or asymptomatic. You want to be able to catch those people and get them to isolate sooner. But again, it comes on to messaging. So one of the things that I tried to communicate was that actually these lateral flow tests, a positive means that you have to get a PCR and you have to get checked and make sure it's not a false positive, but the rate of false positives with them are really low. But having a negative test is not the same thing as being fine. Having a negative, you can be pleased it wasn't positive, but it doesn't mean that you don't have the virus. Early on, there was a lot of talk about using them to pretty much say that everybody was fine in order to go home and see their parents, for example, for university students who were leaving. And it's a really difficult message to get across without being alarmist. But I think over time, that messaging has improved. So come Christmas, I mean, the only thing I'm really going to say about this is that actually, I think all of us knew we were heading for a lockdown come Christmas. But I think, again, it came down to messaging being a bit of an issue. Apologies for anybody who is a Tory, because I'm very much not, with all due respect. and I don't envy Boris Johnson's position, to be fair. It must be a really difficult one. But I think part of the problem was that a number of scientists were probably telling him in the background that actually we need to lock down. We can't have this open Christmas that we really hoped that we could have. And unfortunately, I think he just kept saying no until he said, yes, okay, we need to lock down, which I have sympathy for. But I think from the general public's perspective, even from my perspective, it was incredibly disappointing to have to change things when a lot of people who were taking the virus seriously had tried to do certain mitigations for it. And the other thing about Christmas is that if you were on top of the papers about COVID, then you were already quite aware of a number of variants. And I think they did reasonably well, actually, at keeping fairly quiet so that people could at least try and get some enjoyment at the end of that year until January. But the variants were obviously of significant concern. Anything with an E484 mutation is pretty much a bit of a red flag so far. Thankfully, it doesn't have the same transmissibility capabilities. But in the meantime, we had the Alpha variant. And that's another thing when it comes to messaging, is that actually most people think that something that is associated with more severe disease is the worst outcome for a variant at this point. Actually, transmissibility is the worst thing. It means that when you have widespread, then you actually just get more cases and unfortunately more deaths associated with it. But at this point, we had pretty much wave 2, and academics were again asked to, in some form, try and return to clinical. And we essentially, I tried to get a halfway point so that I was able to carry on with my PhD work, but also support my colleagues in the NHS. So I decided to go back and help with recruitment to further clinical trials. This includes REMAP-CAP and recovery, which shortly after I finished working on them, they announced that tocilizumab was a new treatment for patients, which is again fantastic. And then come January, the JCVI announced this 12-week gap decision in terms of vaccines. Now, at the time, the UK was very much on its own in doing this. There was a lot of naysaying on social media about how this wasn't a sensible idea. Actually, I thought it was an absolute brilliant idea. I think it was a public health emergency that I think most other countries hadn't experienced at that point with Alpha. There was good trial data in terms of the actual clinical trials themselves regarding the effects of a single dose of vaccine and how helpful that could be in terms of reducing your risk of infection. And there was Oxford data which hadn't been released at that point, but had probably, the JCVI would have known, because Andy Pollard, who's part of the vaccine trials, works with the JCVI, he's usually the chair. So the Oxford data specifically showed that with a longer gap between the 2 doses, that improved efficacy of their vaccines. And we've got experience from other vaccines and knowledge of affinity binding maturation, so how well your antibodies will improve over time, that sort of show that actually this was a really good avenue to take at that point, especially coupled with lockdown, which then reduced the risk of transmission further. And I think some of the kickback from other parts of the world, specifically probably the US is what I saw, was partly because they're culturally, I think their population is very opposed to the idea of lockdown. And part of the success of the 12-week idea wasn't just in terms of the actual vaccine efficacy, but also in terms of using the lockdown at the same time to reduce transmission while we got more people vaccinated. So in between January to July, I was mostly at home being a lockdown person. I did get my jab, which was fantastic and just an amazing experience. I had absolutely no side effects from dose 1 or 2 at all. I think I had a sore arm with dose 1 and that was about it. And I think a lot of people just had more anxiety towards it than anything else. It felt so new, I think, to a lot of people. But every now and again, I would help out with the Janssen trial. So this was about April time. We started recruiting to this is the Johnson & Johnson vaccine. And this is Ensemble 2. So it was their 2-dose vaccine trial, which they've just recently press released some information on, saying that a second dose, kind of unsurprisingly, actually improves the efficacy of the vaccine. What's interesting is that in contrast to some of their early data where they didn't think that the time difference between the vaccines would make much difference, in that press release, they do say that you get a 9-fold increase in your antibody response with the second dose at 6 months versus the second dose at 2 months, where you only get a 4 to 5-fold antibody rise. I think it'll be really interesting to see all the results of that data, and it's particularly important for US colleagues. But come April, there was also the issue of this vaccine-induced thrombocytopenia and thrombosis. So some of the best messaging I think that the government has put out over this time period came from this talk by Professor Van Tam, where essentially he showed in a really simple diagram what the risk-benefit ratio was for people who were getting the vaccine versus the risk of the actual virus itself. So basically, when you've got low exposure rates in the under 30 groups, the risk becomes equivocal. I appreciate these are quite small, but ICU admissions due to COVID are about 0.8 in that group per 100,000 people, whereas the risk from the vaccine is about 1.1 per 100,000 people. However, as you go up the age range, that risk benefit tips in favour of the benefit of the vaccine. However, and this is the important point I was making about transmissibility and transmission rates being more important overall than the sort of severity of a particular variant. When you've got a really high transmission, actually it very much tips in favour of the vaccine each time, particularly when you have huge rates. And this rate in terms of high exposure was what we were experiencing at the time of our most recent peak, basically. But it scared a lot of people, understandably. So final things that I just want to touch on as we sort of get up to date is the UK's response to pregnant women and getting the vaccine. Now, there's a long-standing issue in terms of how we run clinical trials and the fact that we don't tend to invite people who are pregnant. In fact, we specifically exclude pregnant people from these studies. And this is something that I think a lot of people, particularly in RCOG, for example, are trying to contend with and trying to improve, because I think it's a real shame. And it's also slightly distressing that as more vaccine trials continued, that we didn't make sure that actually people were included who were pregnant within the trials. I think the UK was too cautious initially. And I understand that, particularly after the backlash from MMR years ago. But possibly now I think they're maybe not being vocal enough. The chief midwife recently called on pregnant women to get vaccinated based on the fact that 98% of COVID cases in hospital in pregnant women were completely unvaccinated. And the remaining 3% were patients who were partially vaccinated. In the US at the moment, because they have such a highly unvaccinated population compared to us, they've seen some awful cases amongst pregnant women. So if you know anybody who's pregnant, who's unsure of the vaccines, I'd direct them to the RCOG Q&A, which is absolutely fantastic and goes through pretty much every question you could ever possibly imagine somebody might have. Aeromedical. So finally, coming on to kids and COVID and vaccinations. So this has been a really interesting debate because obviously the US has decided quite forthrightly to go ahead with vaccinating children, and that is entirely reasonable given the fact that they have very low adult vaccination rates comparably, and therefore they were seeing really high rates of children falling unwell. Now the risk has always been higher for those who are 12 plus. Who are attending secondary school. The risk for 5 to 11s, there's some debate as to whether we allow for natural infection to basically create that immune response in children. Under 5s, again, it gets a bit dicey in terms of the risk benefit because they seem to be slightly more at risk. So when the JCVI looked at what the risk benefits were, essentially, there were obviously lots of benefits, but what they really couldn't quite pin down was this risk of myocarditis. So it is a really rare risk, but when you compare our rates of hospitalizations of children, the risk benefit was actually really quite small. And obviously the first principle is do no harm. Now, it doesn't take much to tip that into being, for vulnerable children, the benefit being much clearer. But it's also the case that the first dose, those risks are lower compared with the second dose. So it wasn't much of a surprise when they looked at it and decided that actually they would focus on giving one dose for now for 12+-year-old children. And I think this just highlights the rates within the US in terms of how unvaccinated the adult population were, and that was associated with 3.7 times higher risk within the States. That's from a colleague called Nini. But I think going forward, there's going to be just more debate now that Pfizer have released data for their 5 to 11 cohort. I think the question will come again as to whether we vaccinate our children over here and what that risk benefit ratio really is. Some of that will be helped by data that's now coming out of the US in terms of the risk of COVID itself causing myocarditis, and further updates on the rare risk of myocarditis with the vaccines themselves. But one final point on this slide that I just wanted to point out was there is a global equity issue. Now, I'm not naive enough to think that us not taking up a vaccine is necessarily going to mean that those vaccine doses go abroad, but they really ought to. And I know that that's a feeling that's held by quite a few people on the JCVI. Andy Pollard himself has made a very public statement stating that he has preference for those doses going abroad. And you can think of this from a selfish point of view. Most of the variants that come about, they originate from poorly vaccinated countries. And so there is a risk to the UK, particularly now that we're opening up our borders much more. But also there's a risk to children abroad where a significant number of them will be losing caregivers. And the whole side of this kind of makes me feel slightly uncomfortable, if I'm completely honest. It's also worth noting that there are other measures that we can still use to protect our children that have just been dropped. I think the last I heard, the Department of Health were thinking about giving out CO2 monitors to help schools find points where there wasn't enough ventilation. But actually that's not necessarily good enough when you don't give them any resource in order to actually fix the problems. And that can be very difficult in various school buildings. We've also always been very slack in terms of talking about masking. I hear a lot from educational specialists or from colleagues who say, well, actually masks are uncomfortable for children, but the US has been using them for ages, and there are some people who won't be able to wear masks, but I think we've kind of dropped them quite quickly. But hopefully at least having one dose will in some way mitigate some spread within children. Which, with that talk on equity and boosters, brings me to my final slides. So essentially the evidence for boosting is there, but most of the evidence for boosting means that actually you reduce your risk of initial infection. But the whole point of the vaccines to start with was to reduce the risk of severe illness and death. And this data out of Israel, originally Israel released data that didn't talk about hospitalization, it simply talked about infection, which, like I said, isn't the point. But there is now evidence that actually having this booster improves the outcomes for patients, particularly in the older age groups where it's more significant that they're more likely to be unwell. And so as a result, the JCVI have released this guidance. I think it's a great idea for people who are immunosuppressed to get a third dose. I think that's really important. And those who live with those who are at severe risk. I can understand the idea for residential care homes for older adults. And in fact, for health and social care workers, I think the benefit is probably more in stopping transmission to your patients. We've had a lot of nosocomial spread, particularly in wave 1, which we've improved on since, but it still makes me slightly uncomfortable. The all adults over 50, I think, is interesting. In the US, they've recently decided to put that to over 65, which I think would be a potentially better decision, but I just wonder how much the use of the Oxford vaccine plays into that, because we know it has lower efficacy than the Pfizer vaccines. But mostly I'm still quite uncomfortable when the rest of the world, like I said, is unvaccinated. And some of what I'm uncomfortable with, what I was alluding to at the beginning in terms of my love for the Oxford vaccine, is the amount of bad press that the AstraZeneca vaccine has had. And a lot of that, I think, is political. There was a bit of a race to get to vaccines. And as you know, I'm not going to lie, as great as it was that Pfizer came out with their results, all of us working on the Oxford trial were slightly disappointed that we didn't get there first, if you like. But overall, it doesn't matter, because the importance is getting the vaccines out there that are safe and effective. The AstraZeneca vaccine forms the backbone of pretty much the entirety of the COVAX rollout. So there are now Pfizer vaccines that are going out to countries that have been donated, I think predominantly from the US. You've donated a significant number of vaccines, which is great. Part of the problem that was coming up early on was intellectual property. So AstraZeneca agreed to allow the Serum Institute of India to produce their own generics versions of the vaccines, which meant that that was easier, and it was all done at cost as well. So it was a lot easier for low resource settings to get hold of the vaccines. When it comes to intellectual property for Pfizer and Moderna, that has been less forthcoming, but I believe is starting to progress. I think I saw something recently about a centre in South Africa, which I think for some reason has been very slow to produce their own generics. I think that's being set up now. But meanwhile, anybody who has ever been to a comparatively low resource setting will know that everybody has a phone. You can live in a comparative shack and still have an iPhone. And so any misinformation that comes out, or any bad press that comes out about the AstraZeneca vaccine, does have an effect on people in those countries who may not get a choice. So, you know, the good thing about the AstraZeneca vaccine is that not only is it cheap, but also it doesn't have the same fridge concerns and freezer concerns. It's therefore much easier to roll out in areas where it's unstable, or where the freezer and fridge supply and resources are limited. And so any bad press really does affect it. I've got family out in Zambia, and I've heard from them. They've messaged me before, sending me things that have come out from various platforms, asking me what's true and what's not. That word does get out. And at the end of the day, no one is safe until everyone is safe. Which kind of comes to, this is like my second to last slide, I think, but it kind of comes to this point, is that, you know, hopefully most of us are in the growth zone, but it has been a learning curve for a lot of people. And I think the important thing in terms of empathetic messaging is to let people know that you can move out of that fear zone, and you can move into the learning zone, and you can even get into the growth zone. You don't have to be tribalistic in terms of your understanding. You just need to work out which resources are best in terms of your education on certain messaging. Now, in the future, I think if I look back, there were times where I'd say I was doing infectious diseases and people would either take a step backwards, or they wouldn't really know what I was doing or what I was talking about. And I think this has really shone a light on how we are a global community, and how an infection in one place can impact on other people. It's also shone a light on diagnostics. And as I said, that's my PhD, so that's quite exciting. And also on vaccines and different platforms for different diseases. I think in the future, we're going to see public health messaging being quite important. I think there's going to be a lot of research that comes out of this. And I'm particularly intrigued by the cultural and behavioural impacts that have changed different countries' responses to the pandemic. And I think any data that comes out of that will be fascinating as well. So I just wanted to thank Public Health England for all of their work that they're doing. Witty and Valence, this is actually the Pet Shop Boys, but they do look like them. And mostly everybody in the NHS for all of the hard work that they've been doing. I haven't had to work frontline this entire time. Obviously, I've got colleagues and loved ones who have, and I understand how hard that has been. They've also managed to put on the biggest vaccine campaign in recent years really successfully. I just think it's a shining example of why the NHS is so important. I just wanted to thank people who've bothered following me during this, and also other fellow psychommers who are putting up the good fight on Instagram and other platforms to try and spread accurate messaging regarding the whole pandemic and vaccines as well. And to thank my supervisors for putting up with me talking about Instagram every now and again, and for their general support. So thanks for having me, and thank you very much for listening.
Thank you, Farah. I really enjoyed. That was really, really enjoyable. Thank you.
Thank
And I
you.
think what it showed was that having good science without